Well, welcome to the 154th episode of the Crisis Jam. My name is David Covington. I'll be your host for today. I'm with RI International and Behavioral Health Link. And terrific to set up the show with tribute to Representative John Roberts Lewis, civil rights titan and Georgia politician. And today we've got quite an innovator in his own right, Dr. Arthur Evans, who'll be talking to us from the APA, Improving Access Through Population Health. I've had the chance to know Dr. Evans for many years, and he is an amazing leader, and look forward to having him on the show today. Talk.crisisnow.com is your go-to location for the resources and supports. And of course, if you're watching this on YouTube and haven't registered for the Crisis Jam, the link in the upper left will get you to that. That's a new process that we started a few months ago. And you can also sign up for our weekly reminder and newsletter, as well as get to all of the highlights from this past week when we marked Canada starting its new 988, as well as remembering Rosalind Carter and all of her impacts to innovate in mental health. If you shoot that QR code with your phone, even as we're on the Crisis Jam, you'll go straight to the YouTube site that has the 150-ish episodes, and you can get to these spotlight episodes. The 988 Goes Live with Dr. Miriam Delphin-Rittman, our most popular episode to date, the special youth edition, episode 108. And of course, there's been a number of great ones that have sparked ongoing attention. The mental health and police from Ron Bruno. We'll come back to that later in the program. And our new ongoing feature that we're coming to every 6, 8, 12 weeks, the big debate. We had our first with Dr. Dave Atkins and Dr. John Draper. AI should be the future of crisis care. We've got our next one coming up. Mental health shouldn't come in a police car. And you can see our placeholders as we begin to flesh out the program for 2024 with future debates. And not just the debates. We want to hear your ideas for featured topics, featured speakers, as well as segments that we might add into the program. Send those to us. What's your idea? We've had, it's actually today that we will cross the 400 mark in terms of unique speakers who have been a part of the Crisis Jam learning community over the course of the past several years. And today we had a Crisis Talk article, Stephanie, a few weeks ago. Aiden wasn't able to join us on the program that day, but I believe Aiden's with us today, a national innovator and leader, and a friend of mine personally. Aiden and Stephanie, welcome to the program.
Hi, are you able to hear me?
Yes.
Aiden, so I'm so excited that you're able to come on. I wanted to chat with you about your new program and the medallions and what the inspiration was.
Aiden, are you with us? So it actually looks like Aiden may not be with us yet. Karen, if you can shoot me a text or chat if Aiden comes on, and we'll come back to this segment.
Yeah, I hope he's able to join.
Couple of news items in Crisis Jam today. CBS News eliminating the stigma surrounding suicide, which featured a number of leaders in the field, but two of our regulars in this learning community, Dr. Christine Moutier from AFSP and Dr. Tia Dole from Vibrant. We'll put that link in the chat area. And there've been a host of ongoing articles the last few years, in particular around the surge of mental health crisis for children in emergency departments. And this particular article in the Wall Street Journal does reference a particular hospital in upstate New York with a pediatric ED, which saw 3,000 kids with psychiatric issues this past year, an all-time high. And a part of the increased demand that they talk about in the article is a shortage of services and families pouring into hospital EDs, where EMTALA says you can't legally turn anyone away. So again, we'll reference that link. And a related article, actually, when we think about demand for mental health services, the AP article talks about the shift with school systems to leverage online therapy as that field begins to just take off. I wasn't even aware of this company, Hazel, which is highlighted in the article, but they referenced that it, as of today, at least 16 of the 20 largest U.S. public school districts are offering online therapy sessions to reach millions of students. And in just those 16 districts, schools have signed provider contracts worth more than $70 million. And of course, they do reference in that article, some of this is exacerbating the challenges for the public sector and private organizations to hire therapists, as we now have this competitor in that online space. So that brings us to the crisis trivia hot seat for the day. And I know Leanne was going to—
I'm here.
Leanne is here. Leanne, you said you might be a
yes.
minute late, and I was hoping that Aiden would give you times, but you're here. So that's great.
I'm here.
So Leanne, you are we talk about regulars on the Crisis Jam, 150 episodes. How many of those do you think you've participated in yourself, Leanne?
I'm going to say 125, 130.
Oh my
I've been
goodness
here.
gracious.
Yeah.
So you've probably been in more than I have. So Leanne, tell folks about your role in Kentucky.
Sure. So I am with the Kentucky Department of Medicaid Services, and I'm behavioral health specialist here. And I'm the program manager for our mobile crisis implementation. We have a Commonwealth model, which is the CMS defined what a mobile crisis team is. And then we have a community crisis co-response grant program that we are having different areas of the state applying for a grant program to develop and implement a co-response model in areas of Kentucky. So
terrific. Thanks for your engagement, Leanne.
Absolutely.
And thanks for the work you're doing. Take in this photograph. This is a almost 4-story and a block long mural that is just outside of the downtown city of Philadelphia, near a couple of the universities there, and got that in your mind's eye. And here's the question: over 1,000 community members participated in the creation of that Philadelphia mural, one of dozens shaped across the city in partnership with the Department of Behavioral Health and Intellectual Disability Services. When I first met Dr. Evans, our featured presenter today, he was leading that department and worked closely with this effort. But the public health theme, and they did murals all over the city, and they highlighted all of these topics over the course of time. But this mural highlights one of the 4 answers here: A, addiction; B, housing insecurity; C, suicide prevention; or D, trauma. And I'll go back to the picture so you can take that in. Leanne, give us your thoughts on that, and whether you want to phone a friend as we're getting the audience's feedback on that. Right now, the audience— trauma is leading suicide prevention by a few percentage points, but we've got people answering all 4 of these.
Okay. Well, my first thought was trauma, especially throwing in the ring to the person on the boat. The loss, I see the woman holding the quilt, that looks like a loss. So I think I'm going to stick with trauma.
So, Leanne, I don't normally do this, but you are such a committed crisis jammer that I'm going to encourage you to phone a friend. Is Dr. Evans, are you here? You can't give her the answer, Dr. Evans, but could you just reflect a little bit on this mural before Leanne gives us her final answer? Dr. Evans, are you with us?
Yes. Hi.
So Leanne is leaning toward trauma, and the audience is got almost double. It's 51% for trauma, 26% for suicide prevention. Housing insecurity and addiction are behind that. But there is, while the buoy, the throwing the life preserver could mean any of these almost.
True.
There are some other signals in this mural that are more explicit. So Dr. Evans, we don't want to give Leanne the answer here, but reflect a little bit on the work that you did. You were part of Did you put paint on this wall, Dr. Evans?
I did not put paint on the wall, but I was obviously very involved in us setting up this way of working to reduce stigma around community issues. And so you're right, the throwing out the lifesaver, the ring is actually a symbol for suicide prevention. And the portraits of the people that you see there are people who died by suicide. And there are a number of other images there that help you see that that this is about not only the loss and the tragedy of people losing their life by suicide, but what happens to the people who are left, who often are isolated because historically people don't talk about suicide, and so family members often struggle with the aftermath of suicide because they don't have that network. And one of the things that happened with this is that we were able to create a new community of people who had a similar experience. Either they were suicide survivors themselves or they were family members, and that was very important.
Suicide prevention, yes.
So
yes.
So Leanne, I think, part of what made that question a little challenging is the community did say, let's not be explicit about this. Let's make this a hopeful and a metaphor, if you will. But it's those quilts that Dr. Evans was mentioning around if you've been to a suicide prevention conference, it is not uncommon for folks to have quilts there that reflect their loved ones who've been lost. So that quilt actually encircles the lake that they're throwing out. So and Dr. Evans, you referenced that the community that was built around that, and the fact that you were also focused on the troubling rate of suicide attempts among African American youth, specifically in Philadelphia, which was an outlier.
Okay.
Doctor, thank you so much, Leanne, for joining us. Dr. Evans, I was looking on Google Maps and I couldn't. So we used to make before COVID, we have a crisis center out in Delaware, and I would fly into Philadelphia with my team. We would make a pilgrimage to that particular mural almost every year. And I was trying to find it. I couldn't find the parking lot. Are you aware that they have built this 18-story, I guess it's student housing, on top of where the Horizon substance use facility used to be and the parking lot used to be? The mural is intact, but you can't see it in its glory. You have to kind of, I guess, walk down that little alley once they're finished here.
Yeah, I was so sad to hear that because so many people worked on that mural, and it really became an icon in the city. And when the AFSP, when they had their Out of the Darkness walk, the national one, that was one of the stops there, and there was a little ceremony. So it really had a lot of meaning, beyond the people who had directly participated. It really became a real symbol for how we should be thinking about and supporting people around the issue of suicide.
Well,
so
terrific. Thanks for your leadership, Leanne. Again, thanks for your engagement. And so with that, let's set up. Dr. Evans, we first met, I think you and I were on the stage. Me, and Denny Morrison were giving TED Talks at National Council like 100 years ago. And at the time, you were still with the Philadelphia department before going to lead the APA. The website for the APA talks about Dr. Evans being an unconventional leader, employing science, research, community activism, spirituality, traditional clinical care, policy and cross-system collaboration to change the status quo. And that's exactly what we've seen out of your leadership, Dr. Evans. Is so thankful to have you on the program today, and invite you to share your PowerPoint and tell us about your thoughts on how we can get better access through population health.
Okay, I will do that. Let me see if I can make sure I get my screen here. Let's see. Make sure you're seeing that correctly. Okay, so I hope everyone sees that. So first of all, thank you so much for inviting me to be here. And I have to say that David is someone that I really respect and admire, really one of the thought leaders in our field. And the one thing that I am a firm believer in is that if we do the same things, we will get the same results. And so we have to innovate if we want to make progress. And I've just been so impressed with the work that David and RI have done, and just wanted to acknowledge that. So what I'm going to do is I always like to be a little bit provocative when I talk, for the reason that I just mentioned. If we do the same things, we'll get the same results. And so I want to talk about population health as a frame, an alternative frame to how most of us were trained. So my background is I'm a clinical and community psychologist. I've spent most of my career either running programs. The largest part of my career really was in public service and running mental health systems in Connecticut and in the city of Philadelphia. And so I think all of us have a mental model for our work, how we do our work, who we are within that work. And a lot of times that mental model is not explicit. We don't think about it, but it's very powerful in terms of how it directs our work and how it directs how we think about our work, and in particular, how we think about solutions. No one on this call has to be told that we had very significant challenges in behavioral health before the pandemic. That lots of people weren't getting access to care, that we didn't have the level of funding that we needed, so forth. And everyone on this call, I imagine, knows that the COVID crisis has really exacerbated that. And when I talk to people literally from around the world, I've talked to colleagues from Africa and Europe and Asia, Australia, they all say the same thing, that their communities, their populations are really reeling from the pandemic. And my belief is that we are in a pandemic that we cannot treat our way out of. And I think a lot of people agree with that, but if we can't treat our way out of it, then what is it that we do? And so that's what I'm going to talk about today. And I'm going to use population health as a framework, a reframing of how we think of ourselves and how we think about the work. So I always like to start with, well, if I'm going to offer an alternative frame, I at least ought to start with the current frame that all of us are trained with. Another matter, if you're a psychologist, psychiatrist, social worker, most of us are trained with what I call the black box model. And the way the black box model works is that we create a black box. It could be a treatment program, residential program, a private practice, it doesn't matter. People get sick, they have depression, they have anxiety, they have whatever the condition is. They come to us, we diagnose them, figure out what's wrong, because that's really important, right? And we treat what's wrong, and then we discharge them well, and that's the way that they derive the outcomes that they're looking for in their life. Now, I will tell you that that model has worked for hundreds and thousands of people. But if we had time, what I would do is ask you, what are some of the challenges with that? And you would tell me a whole series of things. Here's some of the things you would tell me. You would say, well, Arthur, first of all, most of the people who have mental health challenges don't come to treatment. I would say absolutely, less than half of the people. And 10% of the people have substance use challenges. You would say that people don't often know and understand the problems that they have. So one of the one of the symptoms of having, especially a major mental health diagnosis, that you don't recognize that you're experiencing that. And often there is a lot of denial around substance use. You would say that when people come to our black box, often the issues that they come to us with are more complex than we can treat. So if I have a mental health challenge and I go to a program that is a substance use program, or vice versa, or I have a co-occurring condition, often the box is designed to treat a specific condition, and that other condition is not adequately addressed. You would point out that this is an acute care model, that it assumes that with a course of treatment, even if it's multiple courses of treatment, that people are fixed. This is an acute model for what we know are chronic conditions, and often people need ongoing help and support. You would point out that this is acontextual, that it is designed the same way in Alaska or New York or Texas, and that we know that if people are going to recover, that they have to recover within a context, and that the context matters in terms of how we both treat people, but also how we prepare people to live in that context. That's just the short list, right? We could go on for another 10, 15 minutes dissecting and talking about all of the challenges with this as a mental model for how we address behavioral health challenges. But I will tell you that the biggest challenge is it constrains our thinking, because we have this as a mental model. Whenever we ask the question, or when someone asks the question to us in the field, what do we need to do to address the mental health crisis? What we almost always revert to is we need more treatment. We need greater access to treatment. And I'm from the American Psychological Association. I've been a mental health commissioner. I'm a psychologist. I absolutely believe that. But I also believe that that cannot be the only thing that we can do. And I want to build the case for the other things that we can do to help people, particularly in reducing the demand burden, so that we have enough adequate treatment. So let's start with just another conceptualization that drives how we address behavioral health challenges. If this is the population, about 25% of the population will have mental health diagnosis, 75% won't. The way our healthcare system works is that if you're above that diagnostic line, you will get access to treatment. If you're below, you won't. Now, there are a lot of problems with that, because that treats mental health issues as if they're binary. Either you have a problem or you don't. We all know that mental health happens really on a continuum. All of us are on that continuum at somewhere, each one of us. And over the course of our life, we move up and down that continuum. Sometimes we get to the point where we need professional psychological help, but many times we have lower levels of acuity or symptoms that could also benefit. But the way our system works is we assume that the 75% down here don't need anything. And I want to make the argument in a moment that, in fact, we know that often there are subclinical issues here, and that there are risk factors here that put people at risk for having greater issues, or greater mental health challenges. And the other thing that happens is, in this model, there is not a lot of resources for prevention, early intervention, because we're putting all of our dollars up here, and most of those dollars at the very top of the pyramid for people who have the most serious illnesses. So the typical, when I was a mental health commissioner, typically we're spending 95% of our dollars on this part of the population and very little on this part of the population. So the first issue that we have is like, who are we serving? The second issue is, how do we help people? This is a graph of the things that contribute to our overall health status. And one of the things that should scream out to you is that healthcare actually plays a very small part in how healthy we are as individuals. What really drives how healthy we are these things that are behavioral. It's whether we smoke, or we, how, our diet and what we eat, whether we're experiencing stress, human biology, our genetics, the environment that we live in. And the question for us as a field is, if our health status is driven by, healthcare only drives 10% of our health status, what are we doing in these other areas, frankly, that have more of an impact on our health status? And are we doing things outside of healthcare that can help drive the outcomes that we want? So far, I've said that we need to rethink who we're working with, and we need to think how we're working with people. But we also need to rethink where we treat people. And so this notion that people have to come to us in order to get help is a flawed conception, because we know that people don't do that. I just gave you the statistics, right? We all know those statistics. People don't come. And so one of the strategies that we have to employ is embedding services and our strategies and capacity in the places where people live, work, play, worship. And so the population health strategy really is a reframe. And if you take that same diagram of the population, here's what it might look like. So, of course, at the top part of the pyramid, we need to make sure that people who do have diagnosable mental health conditions get access to effective and efficient clinical care. And it's really important to point this out, because sometimes when people hear public health or population health, what they believe is that we are ignoring people with diagnosable conditions. Nothing could be further from the truth. In fact, we have to have an even better game in terms of addressing those issues, because the more efficient and effective we are here, it really helps us with the overall population health. But we wouldn't stop there. We would also be making sure that we mitigate risk and intervene early, that we know the people in our communities who are experiencing greater risk, and we would have strategies to reduce risk or intervene early, and we would have strategies to promote health and keep people healthy. The people at the bottom part of the pyramid, we almost completely ignore in the mental health field in ways that we don't do for physical health. For physical health, we tell people, you should watch your diet, you should exercise, you should get enough sleep. The reason that we do that is we know that if people do those things, they're less likely to have other illnesses. Well, we actually know a lot of things from research and psychological science that can help us educate people so that they're more literate about their mental health and they can be taking action themselves. Okay, so that's the reframe. And everything else I'm going to say is just give you really quickly some examples of how we can do this. And I'm going to go through this very quickly because the first thing I wanted to do is make sure you kind of had the concept. It is a whole population approach. And there are, in fact, things that we can be doing across the population. So at the top of the pyramid, one of the things that the APA does is that we do clinical practice guidelines. And the reason that we do that is there is a lot of research that is produced in this country that doesn't get into practice. And I would also say that a lot of practice should be informing research. That's another conversation. The typical time between when we know something can work and help people and the time that it's widely practiced is about 17 years. So we can do a lot better as a field at closing that gap, doing things like clinical practice guidelines, evidence-based practices, because we know that those are kinds of things actually help us to have more effective care. We can also be addressing social determinants. A lot of times people say, well, we're mental health people. We don't deal with housing or those other things. No, we don't do housing, but we can partner with people who do housing. In Philadelphia, we had an initiative where the mayor negotiated 200 Section 8 vouchers. And the idea was that if we want to solve homelessness, getting more psychiatric beds is not going to solve the homelessness problem. The only thing that will solve the homelessness problem is people having a home. And so we can do our part from a behavioral health standpoint, but we also have to have the other part, that social determinant of having safe housing to be successful. And so we created a project that had multiple pathways I won't go into a lot of the detail about that, but just simply to say, I'm going to show you a little bit of data that not only were we able, with those Section 8 vouchers, able to leverage Medicaid dollars and Medicaid services, combining those two things, we're going to get literally 200 people who are chronically homeless off of the streets every year. And we did that for probably about 7-8 years. And not only were we able to get an 89% success rate in people getting off of the streets, living in housing stably, but this is just some of the financial data. As the 2 years before we engage people, this is what they were costing the system. And you can see as we engaged them, the cost went up. But look what happened in the year that the person was housed. Those costs went down to $18 per person per day. It was a huge savings to the system that we could then reinvest. And it's a great example of a win-win where we're helping people get better clinical outcomes, but we're also being more efficient. What about reducing risk? One of the best ways to do that is to intervene at the earliest possible moment. One of the things, for example, that we did when I was commissioner in Philadelphia is to train people in psychological first aid and send them into communities in the immediate aftermath of a traumatic event. It could be a shooting, building collapse, whatever, as a way of reducing the likelihood and educating people about what a typical trauma reaction is, so that when they were experiencing real challenges, they weren't waiting 20 years before they got help. They could do that much sooner. This is a map of the city. What you see there are places that provide evidence-based practice, evidence-based trauma treatment for children. When I left the city, we had screened about 30,000 children in pediatric settings, identified the kids who screened positively for having been exposed to trauma, and then referred them to an evidence-based treatment approach. So it's a great example of how we don't have to wait until people are in crisis. We can partner with our counterparts in primary care and pediatrics, identify people, and then get them to the kinds of services they need. Again, not waiting. Then the bottom part of the pyramid, let me just give you a couple of quick examples. One of the things that we do at the American Psychological Association is a survey called the Stress in America survey. And we do that not only to track on the areas where people are experiencing stress, but to use it as an opportunity to educate people about how they can manage their stress. We know that stress is related to a whole series of mental health and physical health challenges. And if people can better manage their stress, we can reduce the likelihood that people are going to have deeper in mental health challenges. So it's an example of something that we can do more routinely as a field, which is to improve and increase the mental health literacy of the populations that we serve, so that people are taking actions that can actually help improve their overall mental health. Another strategy, I mentioned the importance of us not waiting for people to come to us, but us going into the places that people are. This is an example. This is one of the things we did in Philadelphia when I was commissioner was we would send teams of people into communities. And you know how you have those health fairs and that kind of thing, you set up a table and you have information. We started doing that around mental health. And when we first started doing it, people said, well, people are not going to go up to a table in a public place that, has a big sign that says, get a checkup from the neck up, right? Turns out that people do. And especially for this group, one of the things that we found is that almost invariably, there was at least one person who was suicidal at the time that we did this. And often there would be multiple people who were either suicidal or in crisis. What does that tell us? That tells us we should, in addition to having the programs and places that people can go, we have to go into the communities where people already are, reduce stigma by saying, here is how you can get help, or here's the information that you could use to help improve your mental health. Here's a screening that can help you identify if you need professional help. The more we do that, the more we're going to reach people before they're in those kind of crises that require them to be hospitalized. And I had actually taken these slides out, but since David showed one of the murals, I wanted to just give you another strategy. And again, these are all examples of things that we did in Philly. But we really tried to use art as a strategy. David mentioned that these are actually painted, these murals are actually painted by the community.
Go back
And
on here.
What is it about?
It's about 988.
And so as one of the strategies to help educate people, we did a whole series of topics. This one was on the immigration and the impact that immigration has on people's mental health. This one was on children's trauma and resilience. This one is the one that we just talked about on suicide. And then this one was on the issue of people who have co-occurring mental health and substance use issues. So that's my story, that I'm sticking to it. And I hope I was able to kind of get us to think about other ways that we can really help reach people, reduce the need for crisis, and get to people much earlier.
Dr. Evans, thank you so much. And there was a comment in the text about how this approach would minimize stigma and shame. We're excited to have Dr. Tobias Wasser on the program for the first time. Dr. Wasser, a quick reflection, comment on Dr. Evans' population health approach.
Yeah, first I just want to say thank you so much to Dr. Evans for a really riveting discussion. And we both hail from the same origins from Connecticut. I'm really impressed with the work you've been able to do. You know, what strikes me in listening to the presentation today is just thinking about how much we have a mismatch problem in mental health care. We have traditional approaches that are very individual based, trying to apply treatment. They don't think about population health in the way that he described, and they really don't serve hundreds of thousands of individuals who have high needs regarding their social determinants of health. And I think our boxes don't fit our people. We have diagnoses and treatments that are overly simplistic. We try to use acute solutions for chronic problems. I really appreciated his point that access is so important, but it's not the only issue, and that we just don't have the resources for prevention and early intervention that we need. You know, I think we reflect on recovery principles about the importance of housing first, work, connection to community, decent nutrition. It was really striking to me how much those connected to the behavioral lifestyle choices and environmental influences on health status in the slide that he showed. And I think it just reinforces so much of what we understand, but have yet to implement about behavioral health care. So thank you so much for giving me a chance to weigh in and for inviting me today to listen to Dr. Evans' presentation.
Thank you, Dr. Wasser. Thank you, Dr. Evans. And look, these are going to be key approaches as 988 continues to transform people's visibility and the opportunity for access. So more to come. Thank you so much. With that, let's go to the SAMHSA update. And we've got James Wright with us today. James, are you with us?
Sorry, David, can you hear me now?
Yes, excellent. Thank you.
All right, perfect. And good morning or afternoon, depending upon where you are. It's still morning here in Houston, Texas, so excited to be here. Super quick, wanted to provide a couple things that are happening right now. If you have not been on SAMHSA's website, on samhsa.gov/988, we have drastically revised the frequently asked questions list here recently. So I do encourage individuals to go on there. Now there's some big changes that we put on there. Now we sort by the questions by 6 categories and really broke out more into mobile crisis care, which I'll talk a little bit about here in a second, but collaborated across the Center for Mental Health Services, CMS, and the Office of the Assistant Secretary to really show that comprehensiveness across what we're doing with 988. Also, there's places for key differences between 988, 911, and 211, and really roles about federal, state, and funding. So if you have a moment, I do encourage people to go on there and check those out. I also just wanted to make sure people were aware that we are going into our second, let me pull it up here, and I'm going to put a link in the web or in the chat. But the second Connecting to Service on, it's called Promising Practices for 988 and 911 Collaborative Webinar Series. So we had our first one in October, on October 12th, and a second one that's coming up here on December 14th, so next week. So if anyone wants to register for that, I just put the link in the chat as well. And then finally, I did just want individuals to know, in the spirit of talking about mobile crisis care, that right now we are holding a mobile crisis summit with the network administrator Vibrant, and also with our partners in the Center for Mental Health Services, looking at how that relates to the work that's going on in CMHS and the work of connecting individuals to those community-based resources post-contact with 988. So hopefully more to come after that, that we can share some of those outcomes. David, I think that's the big updates from SAMHSA.
Terrific, James. Thanks so much. And so exciting to see this work continue to expand to a full continuum, and the power of mobile crisis to get out there and support people with more intensive needs in person. Let's go to Megan. We were talking earlier today about the dramatic way that states are partnering with these efforts. Megan, let us know the state update.
Well, yeah, states are working really hard on 988, and there is so much support. And looking at this map, you'll see that 32 states have been highlighted on the crisis jam, but there are 18 that have not. So we would really encourage those 18 to get highlighted. And if those other 32 have more, please let us know. There's just great work going on across the country. One of the things I just wanted to highlight also was Dr. Evans. Your talk was just absolutely amazing. And you had also presented at our NASHBID annual meeting. At the National Dialogues on Behavioral Health, which took place at the end of October and into the beginning of November, the topic was really about responding to trauma and violence. And so much of what you talked about in terms of population health, the managing stress, the social determinants, early intervention and prevention were all things that so many of the experts discussed in preventing violence. And so I know part of that core piece of having that conference was to dispel the myths that mental illness was a cause of violence, when really it is so much more than that. And so my hope would be that we can take a population health approach, not only to mental health, but also addressing violence. Thank you.
Terrific. Thank you so much, Megan. Speaking of states, let's go to Catherine Gilly with NAMI. That same state map, we have 8 states who've passed comprehensive legislation, 12 who've passed legislation that didn't include all of that, but certainly reflected parts. Catherine, where are we going forward, and how does NAMI seeing this next session?
Yeah, thanks, David. We know of a lot of states who are preparing for 2024 988 legislation, but I just want to flag a couple of bills that are currently in state legislatures. In Ohio, their 988 bill, which was formerly HB 231, has been rolled into HB 354, which is the bill that authorizes adult use recreational marijuana as passed in a recent ballot initiative. It would create a 988 fund and dedicate 12.5% of the marijuana tax revenue for 988. So that is currently in Ohio. And then Wisconsin has a pair of companion bills, AB 467 and SB 462, that are currently in the legislature, and they would dedicate $10 million to establish and support regional crisis urgent care facilities. So we're keeping an eye on those as they continue moving, and definitely looking forward as bills start getting introduced for 2024 sessions.
Terrific. Catherine, we've still got Pennsylvania marked as having pending legislation. What's the status there?
I apologize. I don't know off the top of my
Okay, no worries.
But I can certainly check on that right now and drop it in the chat.
That's terrific. And of course, you can always go to NAMI's reimaginecrisis.org map website that has significant details about all of this. And we're also tracking both NAMI and Guide Consulting, those who are using the new Medicaid options for mobile crisis. We had Leanne talking earlier about efforts in Kentucky. We've got 14 states, including Kentucky, which have leveraged that Medicaid match option. So we are, Stephanie, we started with you. I don't know if Ida
Sue's here, so she's going to join me.
Sue is with us.
Yes.
Okay, well, let's
New
go
Zealand.
to our international correspondent, Sue Murray. I don't know what time it is where you are.
Hey David, how's everyone going there? I'm in beautiful land of the long white cloud. Oh, don't tell me. Am I on mute?
No, you're doing
we can
great,
hear
Sue.
you.
So we've got just
Okay.
a few minutes, Sue. Give us a teaser
Yep.
of the article on more
Yep.
effective investment in mental health.
Yeah, so in this edition of Crisis Health, we're focused on that, the effective investment in mental health, and we've got to better understand economic policy and its impact on our work. So I interviewed Professor David McDade from London School of Economics, and also Dr. Stephen Stack, who is a US economics expert. And both of them have highlighted how important it is and how rarely we actually look at the financial aspects of the programs that we're delivering in suicide prevention and mental health. So the article outlines, firstly, David's sort of thoughts around why this is so important. And then Stephen looks at some of the important structural supports that reinforce how economic policy really can impact suicide prevention and mental ill health. And these are things like unionized workforces, minimum wage laws, financial and nutritional assistance for those in need. And I guess, the importance of this is really highlighted when you think about off the back of COVID-19, everyone agrees the world's facing an economic downturn. And from past experience, we know countries that have provided social and financial safety nets, they've not had significant increases in suicides. So as our governments are grappling across the globe with the ongoing challenges arising from mental ill health as a result of the COVID-19 epidemic, probably further exacerbated by the wars in Ukraine and Middle East, our economic experts point out that we really have to assess investment across social, economic, and health systems so that we can reduce those impending challenges. But if you want to get the detail, get onto Crisis Talk and read that today. Thanks so much, David.
Steph, we have just a couple of extra minutes. Steph, anything in particular that struck you about this? And then I have a quick question for Sue as well.
I mean, it was such a great article. I put some of the points in the comment section. I think this is just something that we need to continue pressing on. I don't think we've done enough articles actually that focus on this aspect and how these supports really, we talk about moving upstream. Well, this is a great way to do that.
So we had the Canada went live with its own 988. They have, in fact, the same 911 emergency medical response system the United States does, the same number, and they now have 988 as well. Where is Australia? Of course, been a pioneer in the Lifeline far before other countries. But where are you with the idea of a 3-digit like the United Kingdom and the United States and now Canada have?
Yeah, so of course we've got the triple O, which is a 3-digit, but it was the equivalent of 911. And so the successes that we're hearing about are certainly starting to resonate here in Australia. So I don't think we're far enough down the track to say that our governments are really focused on looking at a 3-digit suicide and mental health crisis number, but it's certainly something that's starting on the agenda. And it's interesting when you say Australia was such a pioneer in the use of the Lifeline telephone and then crisis and chat services, that we haven't sort of struck this sooner. But it is definitely on the agenda. And one of our chief psychiatrists in South Australia is starting to champion this discussion in Australia.
Sue, the last thing from me, because we have one more segment, but I would like to just tee up the Zero Suicide Summit that will be happening in partnership with Henry Ford Health System and Liverpool's Mersey Care, Joe Rafferty's team in Liverpool, as part of now what is being rephrased the Global Leadership Exchange that will be in Utrecht, the Netherlands. But any comments, because I know you're part of the partnership to host the Liverpool Zero Suicide 5 event?
Yeah, look, I think really what we're focused on is how do we harness this global capability? How do we come to, some key drivers that all countries can think about and work towards implementing? That's one side of the equation. And then I think the other critically important part, particularly in regard to suicide, is how do we support the international movement towards the decriminalization of suicide, particularly in low and middle income countries, which really hampers people's willingness to come forward. So they're two big discussion areas. How can we get that investment and drive the zero suicide framework in and get some global movement happening there? And how can we all join more effectively to advocate for decriminalization of suicide? But there'll be lots.
And I think Sue froze on that note. So we really appreciate Sue joining us from New Zealand, our international correspondent who lives it. There she is. You froze up for a second right there at the end, Sue. But thanks for joining us. Sue's lives in Sydney, Australia, and is visiting New Zealand right now. We're also planning a third International Crisis Summit. We're called Crisis Jam in person, if you will, partnering with an organization that does some really significant crisis care in Amsterdam, and more detail on that as we go. But there will be a host of match sessions. The Global Leadership Exchange is now sharing a number of those opportunities. The one Sue is mentioning will be one of those, and we're going to be having a crisis summit on Saturday and Sunday as well. So while our theme music is coming on, Vic Armstrong, welcome. Let's hear a strong talk for the day.
Absolutely. I made a social media post this morning, as I do every morning. This morning's post read, "We spend a lot of time and energy pursuing things we don't have rather than appreciating the people and things we do have. This holiday season, be thankful for the gift of life and offer someone else the gift of hope by reminding them that their life matters." And of course, I ended it with hashtag Stop Suicide. The holiday season, at least for me, is generally a time of reflection. As we're marching toward the close of one year and the birth of another, I am thankful for many things. I'm thankful for good health, for adequate food and shelter. I'm thankful for my friends and family, but perhaps most of all, I am thankful for clarity of purpose. In a world where there's so much pain and anger and hopelessness, I have found purpose in sharing the gift of hope. And I am not alone, because every Wednesday at this hour, we all gather to share stories of hope, pathways to hope. Whether it's about improving access through population health, or empowering youth to write public policy, or hearing from global partners like Canada's successful launch of a new 988 crisis service hotline, it is all about providing hope. It's about recognizing that the gift of hope often comes in the form of sharing access and influence. It is about recognizing that individuals experiencing mental health challenges or addiction, or those who find themselves experiencing a mental health emergency, should see access to care not as a possibility, but an expectation. Excuse me, and recovery not as an unattainable dream, but as a destination. Recovery is defined as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. It is, in a sense, a new beginning, new hope. What better time than the close of one year and the beginning of another to recognize the power of hope in the lives of those living with mental health challenges and substance use disorders. So, as you celebrate with family and friends during the holidays, remember all of those who fight the good fight every day as they valiantly battle mental health and addiction challenges. Those who struggle to find hope and hold on to social connection. And remember that you helped give them hope. I am thankful for each of you, not only as leaders in this space, but as brothers and sisters who accept the role of being your siblings' keeper. And it begins with recognizing that those who have the most at stake often have the least amount of control over access and influence, and that we have a moral obligation to ensure that the most powerless are kept front of mind, and that we offer them the gift of hope. To each and every one of you, thank you for all you do. You give me hope, and that is Strong Talk.
Vic, terrific. Look, life's too short not to have a big purpose, big meaning, and your statement of purpose in sharing hope, this learning community, this collective impact that we all have working together. Thanks so much for celebrating those who are part of this work. Vic, I do see Ursula sharing your social media on Threads and Instagram, et cetera. Vic, I'm not seeing your TikTok account. What are you behind the times, Vic? Come on.
You know what? I tried TikTok for a while. I guess I'm too old. I don't understand it. Can't use it. Can't do it.
I think you're like, you're one step from TikTok. So we are, we featured in the news a few weeks ago that Harvard University outreached 20 of the most influential TikTokers in mental health and brought them to Boston to try to get them to use more of the evidence-based practices. They found that their uptick was about 2%, which is very, very small. But their audiences were so huge, Vic, that even that slight uptick made this gargantuan. And the other thing was the individuals who went were disappointed that Harvard has this great content, but they don't reach very many people with it. So, hey, more to come. Hey, I see that Aiden has, in fact, joined us. Vic, you were mentioning it's Aiden's birthday.
Yeah, thanks to Facebook. I saw on Facebook it's Aiden's birthday today.
Hey, so look, we've got just about a minute remaining, but I would love to, for Steph, for you and Aiden to have a quick minute.
Yes.
Bring up the
Be
Strong
great.
Talk. Aiden, happy birthday.
Happy birthday, Aiden.
Thank you.
So I wanted to chat about, well, one, I just wanted to talk about the article, but I also wanted to talk about Project to Live and the medallion. So I thought a good starting point would be talking about, you mentioned how rebuilding after a suicide attempt takes having a support system. And that was really the impetus for Project to Live. And if you could just give us a little bit of that background and then tell us about Project to Live and the medallions.
Yeah, and thank you, Stephanie, for writing that article. It was beautiful. I've
Thank
shared it
you.
all around, so I really appreciate it. Doc is on this morning as well, and so most of you, Doc is Ursula Whiteside, but I call her Doc. Is the inspiration, one of the main inspirations behind Project to Live. When I when I was in recovery from my suicide attempt, Doc and Diana Yanez Cortez were the two people that really supported me in rebuilding my life and regaining my health emotionally and physically. And so the two of them, the friendship that we developed over the last 8 years has really been the highlight of what Project to Live is to be. And that is really to connect people to other people across the country, across the world, and let people know that there are other people that are still living after an attempt who want to live, want to rebuild their lives, and just regain the connections that they lost during that time period where, there was a lot of turmoil in their lives. But it really, Project to Live is really about building connections, community, and rebuilding what you've lost in your life. Because a lot of times when a person attempts suicide, it isn't a one-day event. It could be a week, 2 weeks, it could be a couple of years in building up to that. And that Project to Live is just really about rebuilding the connections and holding on to those that love you. And the friendships that you've connected with while you're in that moment of rebuilding. And Ursula has really been my person to support me in the last 8 years of just really regaining, my will to live and also work through all the trauma that I went through in my suicide attempt.
So Aiden, we love you and we so appreciate you being on the program today and talking about this work and more to come. Let's get you back.
All right. Thank you.
Happy
Thank you.
birthday. We
Thanks.
do have a debate coming up. Leanne was talking about 2 different models in Kentucky. We're going to talk about both those models in Crisis Care Shouldn't Come in a Police Car with Sabrina Taylor and Dr. Jen Stuber. That'll be on January 24th. But these next 2 weeks, we have NAMI presenting Hannah and Stephanie on 988 polling awareness and trends. And we look forward to seeing you then. Thanks so much for joining us.